Assalamu alaikum. My name is Dr. Rabia Sajad, and today the topic of gross anatomy discussion is tibia. The objectives of this lecture are to discuss the general features of tibia, attachments on tibia, and the clinical anatomy related to tibia. So, talking about the bones of leg, tibia and fibula make the two bones of leg, and tibia is the second largest bone of the body, and it is lying anteromedial to fibula. This is the main bone involved in the knee joint and also in the ankle joint, and largely this is the bone responsible for weight transmission from femur up to the foot. As a large part of this bone is subcutaneous, this is a quite approachable bone for surgeons requiring bone grafts, and also for medical practitioners requiring bone marrow biopsy, young people, and favorable for intraosseous infusions. Now, as tibia is the long bone, it has upper end, lower end, and shaft. Here we are going to discuss the features of upper end. The upper end is expanded from side to side in the form of two condyles, a medial condyle and lateral condyle. It also has a superior surface which has the articular parts forming tibial plateau for the knee joint, and the non-articular part called intercondylar eminence. The superior surface will be discussed in the next slide. Here we can see anteriorly another part, a large elevation called tibial tuberosity, which is going to give attachment to the strong ligamentum patelli. Both the condyles overhang the posterior surface of tibia more than the anterior surface. And looking at the lateral condyle, we can see that anterolaterally there is a tubercle called Gerdy's tubercle, where the thick part of the fascia lata is going to be attached, called iliotibial tract. Posterolaterally, there is a facet on the lateral condyle, and you can see here that head of the fibula is attached on it, making the superior tibiofibular joint. There is a groove on the posterior aspect of medial condyle for the semimembranosus tendon, and there is a groove on the posterior aspect of lateral condyle for the popliteus tendon. The superior surface of the upper end of tibia shows an articular area which is called tibial plateau, and it is divided into two parts, one on the lateral condyle and one on the medial condyle. And these articular parts are separated by a non-articular area, also called intercondylar region or intercondylar eminence. The articular parts on the medial and lateral condyle of the superior surface are going to articulate with the medial and lateral condyles of femur. As you can see, the shape of the articular area is the medial articular area is oval as compared to the lateral one, and the difference between the area of articulation between between the condyles of femur and tibia are going to be responsible for the rotation process during the locking and unlocking of knee joint. The periphery of the articular surfaces are going to be covered by a fibrocartilage disc on each side called medial and lateral meniscus. They are thick on the margins while they thin out towards the center. And you can see here that their two limbs are going to be attached to the non-articular area on the superior surface, the intercondylar eminence. This is the anterior limb of medial meniscus and posterior limb of medial meniscus, and then we can see the anterior and posterior limb of lateral meniscus. On the central most prominent area of the intercondylar region or intercondylar eminence, you can see two raised tubercles, the medial and lateral tubercles. while the rest of the area is roughened, and you can see attachments of important intracapsular ligaments of knee joint, as well as the attachment of menisci. On this diagram you can see the arrangement here that so first of all there is attachment of anterior limb of medial meniscus here and here. Then you can see the attachment of anterior cruciate ligament. Then the anterior limb of lateral meniscus attaches on this area. Then there is a attachment of posterior limb of lateral meniscus, then posterior limb of medial meniscus, and the posterior most area gives attachment to the posterior cruciate ligament. The lower end of the tibia is also expanded but small as compared to the upper end. It has 5 surfaces and 1 projection. These are anterior surface, posterior surface, medial surface, and lateral surface, and the projection on the medial side is called medial malleolus, which is a palpable structure. The anterior surface is mostly smooth with a small roughened area with grooves of the tendons of anterior compartment of leg. And we have the posterior surface, which is grooved and roughened for the tendons of posterior compartment of leg. On the lateral surface there is a notch called fibular notch, which is going to form inferior tibiofibular joint. On a medial surface, the medial surface is basically subcutaneous, and it is continuous with the medial subcutaneous surface of the medial malleolus. Now looking at the inferior surface, the inferior articular surface of tibia and the lateral articular surface of medial malleolus are going to articulate with the superior surface of talus along with the lateral malleolus of fibula to form ankle joint. Shaft of tibia has 3 borders and 3 surfaces. You can see a very prominent anterior border extending from tibial tuberosity superiorly to the anterior border of medial malleolus inferiorly. This border along with the adjacent medial surface is subcutaneous, so it can be felt on the leg, and these two structures are collectively known as shin in layman language. Then we have medial border extending from medial condyle of upper end to the posterior border of medial malleolus. And the lateral border is extending from the lateral condyle to the anterior aspect of fibular notch. The lateral border is also known as interosseous border, as it is going to give attachment to interosseous membrane connecting it to the medial border or interosseous border of fibula. The lateral surface is here between the anterior border and the lateral border or interosseous border of tibia. And then there is medial surface, which is between anterior border and medial border, and this surface is also subcutaneous along with the anterior border. Then we have the posterior surface, which is the largest surface of tibia. In its upper part you can see an oblique line called soleal line, above which the triangular posterior surface is going to give attachment to an important part, and it is also a part of the popliteal fossa. Below the soleal line you can see a vertical ridge, and this ridge is going to divide the posterior surface into 2 parts, a medial part and lateral part. Now, considering all the general features of tibia, the upper part is the expanded condylar part, keeping the tibial tuberosity anteriorly, and medial malleolus in the lower part towards the medial side. We can easily determine the side of the tibia. In the given slide, this diagram shows tibia of right side. Looking at the attachments of tibia, you can clearly observe that most of the muscle attachment is on fibula here in the anterior aspect, as the anterior border and medial surface is subcutaneous, so it is not going to give any attachment to the muscles, but posterior surface gives attachment to some important muscles. Now starting from the upper end, you can see that there is attachment of iliotibial tract on the tubercle of Gerdy on the lateral condyle. Then we can observe that the quadricep tendon, or we should say ligamentum patelli, part of that quadricep attachment is inserted on tibial tuberosity. Semimembranosus is attached on the posterior aspect of medial condyle on the grooved area. Then we can see on the medial surface of medial condyle and extending onto the uppermost part of the medial surface of shaft, there is attachment of three muscles, which are sartorius, gracilis, semitendinosus. These are the muscles of anterior, medial, and posterior compartment of thigh, and they are collectively known as gyropes or pes and serenus. The lateral surface and part of the interosseous membrane gives attachment to tibialis anterior muscle, which is the muscle of anterior compartment of leg. Rest of the anterior compartment muscles arise from fibula and part of intraosseous membrane. Now looking at the posterior aspect, you can see after grooving the posterior aspect of lateral condyle, the popliteus muscle is inserted over the triangular area above soleal line. Soleus muscle is taking origin from the soleal line of tibia and from the head of fibula. Here you can see tibialis posterior muscle is arising from the posterior surface below soleal line, which is lateral to the vertical ridge, while the surface medial to the vertical ridge gives origin to the flexor digitorum longus. Other than that, various ligaments are attached to tibia and fibula, which can be discussed along with the joints. The articular surfaces on their margin gives attachment to the capsule of the synovial joints, so they can be discussed with the joints. This diagram clearly shows the parts of tibia which are palpable, subcutaneous. You can see the medial condyle here. It is all palpable on the medial surface. The tibial tuberosity, especially the inferior part. The anterior border, which is basically continuation of tibial tuberosity, is all palpable, and the medial surface adjacent to it is also palpable. We can see that medial malleolus, its medial surface up to the end, is completely palpable. Other palpable structures shown in this diagram are patella, which is a sesamoid bone in the quadriceps tendon. Then the medial and lateral epicondyles of femur are palpable, and medial surface of medial condyle is rather palpable part. We can also see that part of the head of fibula, the apex, is palpable, and then the lateral malleolus is completely palpable part. On the heel, we can palpate the calcaneal tuberosity, which is the posterior most elevation in the calcaneus bone. Now, as most of the parts of tibia are subcutaneous, so tibia is a very good bone for bone marrow biopsy in case of suspicion of tumors, and in young people and children, it can also be used for bone marrow transplant. Now, fractures and intraosseous infusion can be discussed in the coming slides. Now, the tibia is the weakest at the junction of upper two-third and lower one-third, where the shaft is thinnest and more prone to fractures. And this part also has a poor blood supply, so fusion of the fractured parts is very slow, and mostly the fractures are compound fractures, in which you can see here that the bones of the leg are fractured and there is an open wound and bleeding can occur with the external wound. We can also see transverse fractures of tibia here in the upper part and also in the lower part, in people mostly who are going on long hiking and they suddenly land on a wrongly angled leg. That's why they are called march fractures or stretch fractures. This slide shows you diagonal fractures of tibia and fibula. Normally, fibula is also fractured with tibia. So, both the leg bones are fractured together. The diagonal fractures may also cause overlapping of the fractured part. This may result in shortening due to overlapping of these fractures. And transverse boot top fractures are the fractures occurring in skiing persons. The ski boot, when the skiing persons are landing on their feet with wrongly angled legs, the ski boot may result in the angle formation and then fractures of this lower one third of the bones. Then in the next diagram, you can see that angle twisting is commonly associated with the malleolar fractures. Eversion or inversion during the twisting is forcefully causing the ligament tears and then fractures of medial and lateral malleolus and also part of lower end of tibia. Intraosseous infusions are not very common in practice, as they are only used when there is extensive injury. For example, in a war, it was extensively used in World War II in injured patients, especially children. It's not very easy in children, and intraosseous infusions are mostly used when IV cannulation is not possible in dehydrated or very bled patients. Intraosseous cannulation can also be done with the war patients, and continuous infusion can be given through that. So we have discussed all the features, attachments, and clinical anatomy of tibia. For further understanding, you can follow the link given in the YouTube video. There is extensive explanation. Thank you.